Everyone, my name is Clarissa and welcome to DNP Mentor. I have been a nurse practitioner since 1998. I do have a doctorate degree and I have specialties in both family practice and in psychiatric mental health. Within mental health, I do have a specialty of depression care. Now, the reason why I wanted to start this channel of DNP Mentor is so that I can provide education to nurses, to other healthcare providers. And also I wanted to provide information and education to individuals that suffer from mental illness. And with that, I'm going to go ahead and get started with the topic for today. And the topic for today is part 2 of medication. Do individuals need to take medications for depression? When is it indicated? And when is it not? If you missed my first part on medication teaching, I'm going to go ahead and put that link below so that you can watch that after you finish with this one. We talked a little bit about, and so just a little bit of a review just so that I can move on and give you sort of like a little bit of why I'm choosing the element of side effect education. So first of all is that an illness, any medical illness, is what dictates the level of any medical illness is what will dictate the treatment, not the individual. So if we have an illness and we want to limit the treatment, it isn't up to us. Otherwise, we're not going to optimize the benefit of any treatment and we might necessarily improve to the best of our ability. And I gave the example, aside from depression, in my video presentation for part 1, give the example of somebody with diabetes where they might need insulin because that's the level of illness that they have for diabetes and they don't want to take it. Now, they can refuse, yes, they don't have to inject themselves, but then their health will decline. So at that point, the severity of their illness is dictating the need for greater care, and in that case could be insulin. And depression is no different. We treat people with lifestyle, education, they make modifications, certainly exercise, addressing stressors, seeing depression as an illness, so to release some of the stigma and some of the negative thinking. Those are elements of treatment. But for some individuals, it isn't enough. Some people know what they need to do, they just can't do it. At that point is when the indication for medication goes with the situation. And so at that point, we might start somebody on medication if they consent. The difficulty is there is a lot of stigma with starting medication. And so a lot of education needs to be provided along those lines so that people can make adequate decisions. So if an individual accepts medications, it's indicated they're going to start medication. One of the first questions that they ask, and I love when I get this question, and I'll tell you why in a minute. They will ask me, Clarissa, how do you know that that's the medication that I need? Why that one? Why that specific, but why that one and why that dose? And so I like the question because it gives me the sense that they're thinking about medication, they're thinking about their illness. And so of course they want to make a conscious, informed decision. But the other thing is that they've been thinking about it, and I like that. So it's not just something that at the spur of the moment, I've convinced them. And so sometimes when I'm providing education, and I don't like that feeling of sort of trying to sell something, because that's not at all what medical providers do. We provide education, information, and then it's up to the individual to accept the treatment. Remember, depression is the same as any other illness. It's no different. Okay, there is a medical biological component. I stress that in almost all my videos because I think that that's very important for everybody watching to thoroughly understand, especially somebody that's suffering from mental illness and or from depression. And so when we assess or diagnose a clinical depression, we base it on the DSM-5, and there's lots of criteria. For some of you that have never heard of that, it is sort of like a guideline, and it will have every psychiatric mental health diagnosis possible. And there's criteria. So a medical provider can't just arbitrarily say, oh, you're medically depressed. So there's criteria. So for depression, there has to be a significant impairment of a minimum of 2 weeks. And these are straight weeks, a consequent, for consecutive 2 weeks. And so either feeling down or depressed or hopeless about half the time for a minimum of 2 weeks, or not enjoying the things that they used to enjoy for a minimum of 2 weeks. And so if you think about it, that would be like 1 full week of not enjoying anything, or almost not enjoying anything, or being down almost, every day, a minimum of half that time for 2 weeks. So that's impactful. I mean, sometimes, we'll have random days where we just don't feel like doing anything, and that impacts us. Can you imagine, a whole week or 2 weeks where it's half the time over an extended period of 2 weeks? So that's significantly impactful. Now, one of the things that I did mention also in part 1 is that certainly, yes, it's the illness that will dictate the treatment. But the other thing is that individuals will hesitate on the medication, starting medication, because of the stigma. And so there's a lot of education that has to be provided in educating people as to what depression is and what are the causes. So that's important to get out of the way. Now, when we go back to diagnosing depression, we base it on guidelines. But the other thing is that when we do that assessment, and for me, I do that PHQ-9, and I covered it in my first video, and I'll go ahead and link also that video below so that if you haven't watched it, you could get a sense as to what I'm talking about. And so we'll ask 7 subsequent questions to have you been feeling down or depressed, or the other one was not enjoying the things that you should be enjoying. The 7 subsequent questions have to deal with appetite, either eating too little or too much, either sleeping too little or too much, problems with fatigue, low energy, problems with concentration, negative feelings about feeling like a failure, moving too slow or too fast. And then obviously also with depression, we also want to screen if somebody wants to hurt themselves, whether it's a planned intent or not. So I mentioned some of the symptoms of depression right there already, which were changes in appetite, changes in sleep, energy level, concentration, and then certainly all the other negative things, the negative emotions, the movement, and also the negative thoughts. But when we choose medications, we choose it based on symptoms. So for example, if somebody comes in depressed and they're not eating, they've lost 10 pounds already within the last 2 weeks, okay, and they're not sleeping. So that will be a different medication than if somebody comes in and they're sleeping all day, or they're eating too much and they've gained 10 pounds in 2 weeks. And so some medications within depression, within the antidepressants, are activators, and some are deal more with helping somebody calm down, will also help with anxiety. Now, to a degree, all of the antidepressants, most of the antidepressants will help also with anxiety, because it's the same brain chemistry that will trigger, that has to do with depression and anxiety. It's the same. And so we use the medications for depression, they're antidepressants, we'll use them interchangeably to also treat anxiety. And so, but some of medications will do better with that than others. So it will depend on the assessment that we're doing that same day. Now, as the symptoms change or improve or deteriorate, we might change the initial medication, and not necessarily that it was wrong to begin with, because it was indicated based on the symptoms of the day, but now the illness went a different way. And so it happens in medicine. It happens with high blood pressure, with diabetes. It happens with any illness. And so the follow-up when starting a medication is key, because a lot of the times we do have to make these adjustments. Now, very, very common, and this is according to research, is that people might get started on medication, but then if there's no follow-up, there's no increase or changes in medications. And so sometimes what happens is people will improve, say within the first 8 weeks, and they get better because they start something, but so not at plateau, but what happens is they stopped improving. And so they give up, and they'll say, well, I started the medication, it was helpful, but they didn't help me anymore. But they never went back to have it adjusted. Now, when we start medication, it's usually started at the lowest possible dose. And there's a reason for that, and I'm going to go ahead and explain that in just a few minutes. But what happens is that it'll start to work, okay, because we introduce it, and it's going to make some changes. It's going to work with the brain chemistry. And I don't want to get too technical in this because I know that I'm speaking to a broad audience, but it works in either inhibiting serotonin. For example, that is one of the most common category for the antidepressants. That's the SSRI, selective serotonin reuptake inhibitor. And so it starts to do that. And so what happens is people will improve, but then what happens is it'll adjust to how the body is going to accept it. And so it's not working before. So very common when there's a dose that needs to be adjusted is I was doing great when I started it. First 2 months, I was doing better. I was doing great. And then after that, it sort of just leveled off. But that's the reason, is that they need an adjustment and they never went back for it. And sometimes they get discouraged and maybe they don't come back. Although some say to me, I tried medication. Well, trying medication for 8 weeks on the lowest dose and only one isn't trying. That, because there's so many more options, we have to optimize the dose and maybe adding different adjuncts depending on the level of illness, just like with any other illness. Now, why do people have side effects? If you think about side effects for any medications are not uncommon. In fact, if you were to compare the packet insert that the pharmacist gives you when starting an antidepressant, when starting antihypertensives, when starting medication for arthritis or any other illness, you're going to get a long list. Depression is no different. Now, what happens is that we are introducing something to you in hopes that it will create a change, because the way your body is handling something, it isn't working. Thus, illness. And so when we introduce an antidepressant, we want a change in how your brain chemistry adjusts itself and how it does the things that it's supposed to do to regulate your brain. We want to create a change. And so what happens in the body is that it does not like change. It hates it. It hates any change, not just with antidepressants, but with other areas of medicine. So I commonly give the example of having somebody started on antihypertensives. Now, usually when somebody starts on a medication to regulate their blood pressure, they don't always have a big choice. Otherwise, unless they want to have a heart attack or a stroke. And so I have seen patients where they will tell me, I got put on this high blood pressure medication and I feel worse. And I'll look at their medical record and I said, oh yeah, oh my goodness, your blood pressure incidentally was 200 over 100 when you went to your primary care to take care of a headache. And wow, you could have had a stroke. And they said, yes. And so they bring it down immediately. They don't gradually bring it down. They want to bring it down today. And so they will give them the medication, sometimes one, sometimes two. And so what happens is that it'll bring it down as quickly as possible. And so while their body adjusts to the change in the blood pressure, even though now it's going to be normal, it isn't their normal. And so for the first 2 weeks, they'll have headaches and brain fog and dizziness. I had one specific gentleman that I saw when I was seeing patients in person before COVID, that I called his name and he got up super slow, and I knew this patient, so it wasn't him. And initially, of course, I think, oh my God, something happened. The depression is worse. So he's walking in very sluggish. He puts his head, on his hand like this, and he's just talking to me. And I go, what happened? What happened? And I'm doing the assessment for the depression. And so then he tells me about the blood pressure medication, and he says, I'm going to stop it because it makes me feel worse. And I said, oh my God, don't stop it, because that's what's supposed to happen. You're creating a change, and this is the way it is. Now, after 2 weeks, as your body adjusts to this, you will feel back to your baseline, because now your body has gotten adjusted to a new baseline. And so that's why high blood pressure is a silent killer, because it goes up slowly over time. It becomes a baseline. It's still creating damage, even though they don't feel bad, but it's still creating damage because our bodies are not meant to sustain that level of blood pressure. And so it's creating damage affecting kidneys and eyes and heart and all that stuff, but they don't feel it because they've gotten used to it. So with depression, the side effects are mainly related to that change. Now, there is an exception. I'll go over that in just a moment. So common side effects, anything that the brain controls, everything. It controls everything. So headaches, brain fog, dizziness. I had one patient that called me after starting an antidepressant, and she said to me, my eyebrows are falling. And she had an appointment the following week, so she just wanted to ask me, should I continue? There was nothing else. There was no change in suicidal thoughts or anything like that. In fact, she was feeling better, and her partner told her, check it out. Don't stop it because you're doing better. And so I said, well, if, I did the whole assessment, and I said, keep going, and I'll see you next week. Unless there's a change, let me know. And then we can make a decision at that time. So by the time she came in, it was about 7 or 8 days later, I looked at her eyebrows and they were fine. Now, do I believe that her eyebrows were falling off? Yes. Because when you think about it, anxiety and depression, very common. People will lose their hair. And a lot of times they will come in for treatment, not because they want medications for mood, but because they don't want their hair to fall off. And so I believe it, yes, because anything that the brain controls. Now, if any of those side effects happen, they usually will happen within the first 2 weeks, and they level off and they resolve. Okay, it's only during that adjustment phase. So very, very common. Now, there is one side effect that has a black box warning. Now, what's a black box, right? And so I'll explain that to you in just a second. But if that side effect presents itself at any time, especially during the first month, is usually when we'll see it, but it could happen at any time. But less likely as time goes on. And that's when people become more depressed, or when they have the opposite reaction of what we're trying to treat. So if any of you have heard of people that become more depressed or even suicidal while being on antidepressants, there is a reason, and I'll explain to you in a second. Now, let me get to the black box warning first. So when you look at the side effects of any of the medications, they're just a list. So the FDA, what they did is they wanted a potentially life-threatening side effect to be highlighted. So what they did is they put a black box around that side effect. So if you look at antidepressants, it'll say increased suicidality, suicidal thoughts, or potential for stroke, depending on which medication. But for a typical antidepressant, it would be increased thoughts of suicide, either thought or intent. And so that happens, and it happens in a population that have not necessarily an MDD or major depressive disorder, but it happens in people that have a bipolar 2 depression. And so bipolar 1 and 2, there's a difference. So with bipolar 2, instead of people having mania, big mania as their main symptom, they have depression. So they have episodes where they'll spiral down. And this will be throughout their lives. They'll spiral down. Now, the bi part is they do have to go a little bit above the normal mood, not necessarily up here, but they go above here. They call that mania, where they'll have episodes where they're more confident than others. They more goal-oriented. They are more talkative, more social. And so there's a difference from the baseline, but the big symptom in bipolar 2 is the depression episodes. And a lot of times that's when people will come in for treatment. So a lot of the times, if it's a milder, I shouldn't say a lot of the times, but some of the times when it's a milder bipolar 2 illness, it could mimic the same as major depression. And so what happens is that they'll put an antidepressant, and so it'll activate the bipolar 2, and so that these are the people that typically will have the suicidal thoughts, because the treatment for a bipolar disorder patient is not an antidepressant. It is a mood stabilizer. So it doesn't cause bipolar depression. It'll activate something that's already there. So in my mindset, and usually most of the clinicians that I've seen, that I've worked with, is that they will rule out bipolar depression before starting somebody on an antidepressant. And so we will ask the questions. We will make the assessment, especially if it's their first time. Now, if somebody has been on antidepressants in the past, and either they've worked or they haven't worked because it didn't make them more depressed, but it wasn't for them, then the suspicion will minimize, because it's not going to be one specific antidepressant. It's usually going to be antidepressants in general. So I hope that educational piece is helpful. The key, though, when starting medication, is to be in contact with your clinician, with your provider, updating them in terms of what your side effects are, this normal, this not. But typically a good provider will teach you on what to expect and when to give them a call. So the key, though, probably there is to find a clinician that will take the time to do that. And there are tons and tons of responsible providers that certainly will do that. And medication education takes a long time. And so, and which is why in mental health, we sort of get longer appointments. Typically for a follow-up is 30 minutes, and then an initial will take an hour. And believe me, we use all of that time. If you have any questions regarding medications or why we get side effects, I hope that you will leave those questions for me in the comment box. Also, if you have additional topics that you would like for me to discuss, I hope that you can also make a comment. And at this time, I hope that you take the time to also like this episode and also subscribe to my channel. Thank you so much for your time and for watching. Have a great day.